Hello, my name is Gytis Baranauskas and I'm an otorhinolaryngologist here at Nordesthetics. Today we're going to talk about functional nasal surgery. When talking about nose surgery, you have to understand that nose should not only look good on your face, but it should function properly. So the nose has this important function. It humidifies, warms and conditions the inspired air while removing airborne particles before they reach the lower airway. Let's talk a little bit about the anatomy of the nose and of all the structures in the face that contributes to nasal breathing. So first of all, we have this nasal skeleton, which is consisted of nasal bones. It is placed in the middle of the face, which this aperture is called the piriform aperture, in which there are nasal concha and nasal septum. Nasal septum is divided in two parts. The first part is quadrangular cartilage, and the second part is the bony part, which is made from the perpendicular plate of the ethmoid and the vomer. Looking from the outside, nose has these cartilages, the middle vault, which is composed of upper lateral cartilages. The lower third is made from the lower lateral cartilages or alar cartilages. Talking about nasal breathing, it is important to mention nasal valves. For many years, nasal function was linked directly to the septum or inferior turbinates. However, the area of interest in the airway is the region in the nose, covering 2 to 3 centimeters from the external nares, controlled by hard fixed tissue structures, mucosal changes, and a variably dynamic lateral nasal wall, together with clearly defined ligaments. So when we are talking about nasal valves, there are two nasal valves. One is external nasal valve and the other is internal nasal valve. The internal nasal valve is the area in the nose which is the most narrow. So if we would look in this picture, on the right-hand side, the dark color, dark blue, is outlined the external nasal valve and the internal nasal valve. Basically talking, the external nasal valve is right here where the nostril begins, and the internal nasal valve is the part in the middle between the upper lateral cartilages with the junction with the lower lateral cartilages. So there is a huge benefit in recreating stability in the valve region, as the majority of surgical procedures weaken or destroy its various elements, leading to insufficiency and a reduction in function. There are a lot of nasal obstruction causes. In this chart you can see, well, just a few of them really. So they can be like neoplasms, benign or malignant. There also can be inflammatory causes like rhinosinusitis or nasal polyposis or just rhinitis. There also might be some infections which can cause obstruction. Also there are congenital anatomic disruptions. The obstruction might be caused because of some medications that you are using, and so on and so forth. Trauma is one of the most common cause of obstruction because of the trauma when the nasal bones and nasal septum are disrupted. So differential diagnosis of nasal obstruction is broad. The etiology of nasal airway obstruction can be multifactorial and often contains pathology from both the anatomic and physiologic aspects of the nasal airway. This is a more simple chart in which you can see the causes of nasal obstruction. This is the three parts, like mucosal changes, structural changes, and sensory causes. Today we're going to talk more about structural causes. Let's begin with the deviated nasal septum. A septal pathology contributes to almost all nasal deformities in a high percentage of all patients seen in rhinological practice. Septal deformations are the main cause of functional complaints. In many cases, they are also the root of aesthetic complaints. So when we are saying that you have a deviated nasal septum, it's most often the true, because about 90% of the population has a deviated nasal septum. But when the septal deviation does not cause any obstruction, it's okay. It's like normal anatomy. When septoplasty is needed, septoplasty may be required to correct a deviated nasal septum which causes obstruction for nasal breathing. So if there is irreversible symptomatic nasal obstruction, septoplasty might help to improve the access for endoscopic sinus surgery, or let's say if you have like migraine type headaches or you have severe nosebleeds due to septal spurs or something like that, so septoplasty might be an option for you also. Nasal septum comprises the medial border of the nasal airway, air and nasal valve on each side. Even a small deflection in the septum in the valve region can play a large role in nasal airway obstruction. So anterior septal deviations, often in the region of the nasal valve, may be more likely to cause the patient significant symptoms of nasal obstruction, whereas posterior deflections in the back of your nose typically need to be larger in order to cause some problems. So when the septum causes obstruction or aesthetic discrepancies, so septoplasty is needed. In this photo, you can see a CT scan of paranasal sinuses, and the white arrow marks septal spur on the left side, which has contact with a lateral nasal wall. In this scenario, the patient might have, but also might not have any signs of obstruction, but the patient, he or she might have severe migraine type headaches when the pain is located behind the eye, or might have some severe nosebleeds, recurrent nosebleeds, and sinus pathologies. So septoplasty. Septoplasty refers to surgical manipulation and or removal of deviated septal cartilage and or bone to correct a nasal septal deformity. It is a functional procedure. The goal is to alleviate breathing by straightening the cartilaginous and or bony part of your nasal septum. Septal corrections form an important step in rhinoplasty, not only for functional but also for aesthetic surgery. The septum deserves attention. So it might be, let's say, two types of septoplasty. One is more radical when we leave only like a L-shaped or delta-shaped strut. It's the photo on the left-hand side. And it is more preservative when only the deviated parts are removed. In this example, the junction between the cartilage and the bone. Or you can remove some deviated parts, straighten them, and insert them back into between the mucopericardial flaps. Another cause for nasal obstruction might be middle turbinate concha bullosa. It is a large concha that can be attributed to nasal obstruction. There is a correlation between unilateral concha bullosa and the septal deviation to the contralateral side. Most often the concha bullosa is on the one side, as mentioned before, but in order to treat it well, a CAT scan is mandatory actually, because the middle turbinate attaches to the skull base, so if it is managed not properly, it might cause cerebrospinal fluid leak, which we wouldn't like to have. You also. Inferior turbinate hypertrophy. The inferior turbinate has a number of important functions, including airflow warming, humidification, filtration, and mucociliary clearance. However, pathologically enlarged turbinates can also play a significant role in nasal airway obstruction. In these pictures, you can see where white arrows show two enlarged inferior turbinates, which causes nasal obstruction. On the right-hand side, it is graphically showed how the inferior turbinate looks. When dealing with inferior turbinate hypertrophy, one must be very careful, because overzealous resection or reduction of the inferior turbinate might cause even bigger nasal obstruction, which is called empty nose syndrome. You may look to your nose with a nasal speculum with an endoscope and see your nasal pharynx from the beginning of your nostrils. And you might say that there is plenty of space and why I'm not breathing. You're not breathing because the mucosa of the inferior turbinate was removed or was destroyed, and the receptors in the mucosa are gone, and now your brain does not understand that you are breathing properly. So you have to take that in mind, that if you have inferior turbinate hypertrophy, the surgery must be, well, minimal as possible. There are different types of turbinoplasty, like radiofrequency, laser cautery, medialization, lateralization, piezo-assisted turbinoplasties. There might be also like partial inferior turbinectomy or total turbinectomy, but as I mentioned, it is very dangerous to have this procedure done. When we were talking about the middle turbinate resection, concha bullosa, the one and the main treatment is a partial or a total resection of the middle turbinate. It is safe because middle turbinate does not contribute as much to nasal breathing as the inferior nasal turbinate. There are different techniques, but actually the goal is the same: is to reduce the size of the mucosa of the whole turbinate, and to lateralize it as much as possible to make airway bigger. When talking about nasal valve narrowing, the internal nasal valve is the narrowest part of the nasal airway and is the site of the highest nasal airway resistance. So as mentioned before, we have external and internal nasal valves. On the right hand side, you can see this cross-sectional picture in which the nasal isthmus is shown. It is like three-dimensional part of your nose where it is combined of lower lateral cartilages, upper lateral cartilages, nasal septum, and the piriform aperture, also the heads of the inferior turbinates. So this is, as I mentioned, most narrow part in your nose, and if it is too narrow, or sometimes if it is too wide, you might also feel obstructed. So you have to have in mind that when treating nasal obstruction, this part must be addressed also. Internal nasal valve surgery. There are different types of surgical procedures which can be done to make the breathing easier if the cause is internal nasal valve collapse. So in this slide, you can see types of grafts or flaps, so-called spreader grafts or spreader flaps. Spreader grafts are tiny pieces of cartilages which are taken from your nasal septum, or if you don't have sufficient amount of cartilage in your nasal septum, then we can take a part of your rib or ear cartilage. They are cut into the slivers, and they are inserted in between your upper lateral cartilages. Then goes the spreader graft, and then goes the septum. So its function is to make the internal nasal valve area wider, to make the angle between the upper lateral cartilages and the nasal septum to be about at 10-15 degrees. It's the normal valve angle, internal nasal valve angle at the junction of the nasal septum and the upper lateral cartilages. So as mentioned, this effectively widens the nasal valve area and improves the nasal airflow by lateralizing the upper lats. So cosmetically, the placement of spreader grafts are used after hump reductions, and they are employed to maintain the appropriate width of the middle vault on the end of your nasal dorsum, and to avoid to get this inverted V deformity when it looks like when your nasal bones are detached from your upper lateral cartilages, and you see that dropping of your middle vault into your nose and the shape, and there's this shadow-like inverted V, so it's not aesthetically pleasing. There are also different types of sutures which can be used to expand the nasal valve. From the left-hand side, the first two pictures are a Z-plasty, which is made from the upper lateral cartilages and the lower lateral cartilages. The two flaps are interposed and switched to make the internal nasal valve bigger. Then there is this third picture, like tension spanning sutures, to just lift the lateral borders of the upper lateral cartilages. And this fourth picture, you can see so-called procedure, a valve lift, when the barbed surgical threads are used to elevate the internal nasal valve. And in the last picture, you can see a composite graft, which is inserted as a type of so-called butterfly graft. It goes on the caudal end of the upper lateral cartilages and under the cephalad part of the lower lateral cartilages. In that way, also lifting the lower lats and expanding the internal nasal valve. External nasal valve surgery. There are also some different techniques to strengthen the external nasal valve. Most oftenly, it is done by using grafts. Most commonly used are alar batten grafts, alar strut grafts, alar rim grafts, or lateral crural strut grafts with or without repositioning. So the goal is to strengthen the lateral nasal wall in the region of the external nasal valve so that it wouldn't collapse when you inspire forcefully. There are also some different other techniques that are not so commonly used, but they are available, like this flip-flop technique that you can see in this picture. So when we have the anomaly of lower lateral cartilages and we want to set them as anatomically as possible, so you have to take whatever is in your pocket. Piriform aperture stenosis. As I've said before, this site, as you can see in the CT scan on the left-hand side, two white arrows shows the stenosis of the piriform aperture. If you remember, this is the place where the nasal isthmus is. It is the most narrow part of the nose, and in this case, it's even more narrow. So to widen it, to make it broader, to alleviate breathing, this type of surgery called maxillectomy might be needed. It is, you can see on this graphical side, on the picture on the right-hand side, this piece of bone is chiseled, is bared, or just bitten out with rongeur to make the part where the inferior nasal turbinates attaches, to make it wider so that you could lateralize the inferior nasal turbinates and to expand the piriform aperture. Form and function are much related. A systemic, adequately projected and supported lower two-thirds of the nasal skeleton is likely to produce a balanced nasal airway, limited only by the resistance provided by the isthmus. So you have to remember that the beautiful nose is the one that breathes well. So choose your surgeon wisely. If you have any other questions regarding nasal surgery, feel free to contact us at Nordesthetics.